Are you there? Okay.
And good afternoon, everybody. On behalf of BPNI Maharashtra and UNICEF Maharashtra, as well as the Bureau of Nutrition Maharashtra, a warm welcome to all the participants who are there today. And y'all are in for a lovely feast on this particular lecture. And this is our fifth IYCF clinics at
Sixth one.
sixth, I beg your pardon, sixth IYCF clinic at Maha BPNI. And today we are going to cover an unusual topic. And the topic is misdiagnosis to clarity and uncommon mastitis. This will be delivered by none other than Ritika Bhandari. She is a dedicated breast oncoplastic surgeon for the last 3 years with a focused experience in benign and malignant breast diseases. S- She specializes in holistic breast care, combining surgical precision with a compassionate and patient-centered approach. She has completed her advanced training in breast oncoplasty and has worked under eminent mentors, including at Tata Memorial Hospital and other reputed institutions. She has expertise in breast conserving surgeries, sentinel lymph node surgeries, biopsies, and reconstruction techniques. And she has a special interest in breast health awareness and early cancer detection. Currently, she is at KIMS Hospital, Thane, and she also runs her own private clinic for breast health, where she emphasizes personalized care, education, and area of an empowerment of women across all age groups. Of course, her area of expertise is benign and malignant breast diseases, oncoplastic breast surgery, breast cancer awareness, high risk screening and genetic counseling, and cosmetic breast procedures. And very warm welcome to Ritika Bhandari today for this particular session. I hand over to Ritika.
Yeah. Thank you so much, ma'am. I'll share my screen.
Ritika is also, enrolled herself for this year's IBCLC class.
Yes.
Yeah. Can you go on full screen, please?
Yes, ma'am.
Relax, no problem. You will get to it. Present full screen.
Yeah.
Yeah.
Okay. So, good afternoon, everyone. On the behalf of VPNI, ma'am, and Dr. Gangal, sir, I want to thank you all for the opportunity. I'm basically a breast surgeon, and I have seen many patients during the time of the lactation. They have so many issues, but this is a rare case. So, I thought, why should we discuss among ourselves? So, this is a very rare form of mastitis, which I'm going to discuss. So this I will be discussing about the case presentation, demographic, idiopathogenesis, clinical presentation, imaging and treatment. So my patient, she's a 28-year-old female. She's a native of Thane, presented to a obstetrician 7 months pregnant with several months of pain and swelling in the breast, basically in the left breast. Then, when she went to a obstetrician, she thought it must be a mastitis because there is redness and swelling. So she advised to get an ultrasound breast done, in which there was a ill-defined hypoechoic mass lesion which is seen. So this is the ultrasound scan which was there. So as you can see, this is a hypoechoic lesion which is ill-defined, which is seen in the left breast, 10 o'clock position. So she was started on antibiotic and painkiller for 7 days, and then she was asked to follow up, but there was no improvement noted. So then they changed the antibiotic to some other line. So first she was started on amoxiclav, then they changed to Ceftum antibiotic also. There is a bit of improvement, but there is a period of waxing and waning of these symptoms, and then she was referred to me for the further management. So how exactly we see as a breast surgeon to these cases? So first of all, in any kind of a breast situation or any symptom which is related to the breast, so we follow triple assessment. So first is the clinical examination, then is radiological examination, and if needed, a pathological examination. So first of all, our focus is the detailed clinical history of the patient, followed by clinical examination and imaging, and if needed, a biopsy. So when this patient came to me, and she has, sorry, I don't have the first image of the patient, but I'll be showing you the before after. After first visit, I was not able to take the picture. So she's basically from Pune, but she came here for the delivery, and afterwards, for 2 3 months, she was with me. So first of all, when she came to me, she has erythema over the left breast, exactly 12 to 2 o'clock position I can see. And there is a discharging sinus which is there. There is some kind of mild pus discharge which is there. So first thing that came to my mind, I asked her about any history of fever which is there, any history of weight loss, because the first the differential diagnosis which come to our mind is a TB, as being an Indian population. So I asked her a history of weight loss, loss of appetite, because there was minimal pus discharge. There is no clear cut lump which is palpable. There is no nipple discharge. There is no family history of any malignancy, and patient doesn't have any past history of TB. So then I got her normal blood workup done. Her CBC are within normal limits. TLC were also normal. ESR is bit raised, and the pus culture is negative for AFB. And there is because she was on antibiotic course for so many days. So this can happen multiple times that there is no growth which is seen on culture. So what I'm able to see is 12 to 2 o'clock, there is erythema and a bit of nodular feel which is there. So then, just to rule out, because it is something which is a recurrent mastitis, we can say. So I advise her to go ahead with the USG guided breast biopsy. So in the breast biopsy, it came out as non-necrotizing granuloma with localized infiltrate of multinucleate giant cells, epithelioid cells, lymphocytes, and plasma cells. So this was the kind of picture which we get. So this is something which we called as lobulocentric infiltration. So in TB and in this kind of a picture, this lobulocentric features are not seen in the TB, which differentiate it. And it is kind of a non-necrotizing granulomas with multinucleate giant cells and plasma cells which are seen. So it is like a chronic mastitis or chronic inflammatory kind of picture which is there. So then I also get a X-ray. So I also usually sometime I ask the history of any joint pain on any recent origin or in the past also, because sometimes it can be related to some autoimmune etiology also. So if that symptom is there, I usually send the patient to a rheumatologist for a serology workup, which is ANA and rheumatoid factor. In this patient also, I get it done, and it is negative. Digital mammogram, if you ask, so digital mammogram is not required. Ideally, mammogram is not required below the age of 40 years. But if sometime there is a clinically palpable lump, we do get a mammogram done just to see microcalcification. If we are suspecting a pre-cancer BCIS kind of a disease in some patients. An MRI is only done when there is any clinico-pathological discordance which is there. It is rarely done. And then I sent this also. I sent her for gram stain and PS culture sensitivity gene expert also. And sometimes sarcoidosis also we have to keep in mind. So this was the image of my patient. So basically, this is something which is a diagnosis of exclusion. So I'm talking about idiopathic granulomatous mastitis. everything is ruled out, and then at last, because TB is the most common differential which is there, but gene expert for TB and autoimmune serology was negative for this patient. So if sometime this patient came and if the diagnosis is TB, and if suppose by any chance means there is some discordance with the pathologist, sometimes pathologists see the granulomate, means there is a need of very good pathologist to make a diagnosis of granulomatous mastitis, because it can backfire also. If we start the patient with the tuberculomastitis with a steroid, it is going to increase the disease and the rhythm and all the situation. But other way around also, if we give, obviously it is a medical legal case also, if we are giving TB to a patient who is not proven tubercular disease, but otherwise also if we give TB, in granulomatous mastitis TB treatment, then also it is going to flare up. So the diagnosis, the histopathological diagnosis is very important in these cases. So then I started the patient seeing the diagnosis of granulomatous mastitis, and already patient is on multiple lines of antibiotics. So if sometime this picture came, so we have to start the next line of treatment, which is a steroid treatment. So first of all, I started her with the 16 milligram per day dose of steroid, which is BD for 5 days. And we used to taper it. First, we see any difference, like it will take maybe a week or two, and accordingly, then we taper the dose. So the patient experienced improvement in the pain and the swelling during this time, and it taper concluded within 3 weeks prior to the delivery. So no further steroids were prescribed in order to prevent any further. So in oral steroid also there are so many side effects like blood pressure, cushingoid features. So they are also not prolonged to that duration, so that there is no complication at the time of childbirth. So the patient began with breastfeeding after the delivery and continued to breastfeed from both breasts. So there was
Manisha.
quite of improvement
Thank
which is seen in the post.
yeah, Manisha. Ma'am.
So she presented at 4 week postpartum to me for evaluation. There is again worsening of the symptom which is seen in the left breast despite being compliant with prednisolone. So that time I was able to see a very large mass with erythema and induration in the left breast, which is extending right from 9 to 4 o'clock position in the periareolar region. And the mass measured around 8 into 9 into 8 centimeter in the total size, but no fistula was seen. Taper discontinuation of steroid over the course of 1 week, and then so basically if we have already given an oral steroid, so our next line of management will be oral ki bajaye we give intralesional steroid injection to the patient, which will, because we can't start the steroid taper, stop again, start taper. So in this case I started with the intralesional steroid thing. So it is, I'll show you the video also. So basically, triamcinolone acetate was given 40 milligram, which is a 1 ml vial. And I mixed that with lignocaine, 2%, 3 ml, along with the normal saline to make it 10 cc. And then we give along the cavity, wherever we find the lesion. So we give in the wall, anteriorly, posteriorly, medially, laterally. So this is a topical steroid kind of a thing. So with this, her breast pain improved drastically and the mass has also decreased in size. So usually the steroid dose we give once a month or 3 weekly, and then we see how the response is, and accordingly we can give it for 3 to 4 months also. So she has developed a new discharge draining fistula at 1 o'clock, and then additional steroid dose was given. So this was the picture, and this was after the first dose of triamcinolone, 6 weeks postpartum. You can see there is a fistula which is there at 1 o'clock position, and this is 10 weeks postpartum. There is quite a bit of improvement which is seen. So at 3 weeks follow-up, there was a decrease in this mass effect and the erythema, and she elected to resume breastfeeding from the left breast and start on the oral prednisolone. So there is an issue with the topical dose of these triamcinolone acetate, because what happened when we give that, we inject that, and when the female is breastfeeding also, so the drug has a tendency obviously to go through the breast milk to the newborn child. So it it can cause side effect of those steroid, and there can be growth suppression, etc., in the newborn. So we can't give this steroid medication, topical steroid, to the patient in that heavy dose during the time of breastfeeding. So, what exactly is this condition? So, this is idiopathic granulomatous mastitis. As the name suggests, it is idiopathic, means the cause is not known. It is a benign, rare, chronic, non-inflammatory disorder, which was first described by Kassler and Worrall in 1972. So, the first differential diagnosis after seeing this picture is obviously a tubercular mastitis, and next differential diagnosis that will come to my mind, it can be an inflammatory breast cancer, so something related to carcinoma of the breast. So definitive treatment of this always remain controversial. So if you ask me about the non-lactating females, so first of all we give them antibiotic obviously to control the infection, and then we move on to steroid therapy if there is a recurrent kind of abscess, and we can also start the patient on immunomodulators also. But because she presented to me 3 weeks before her delivery, and then in the lactation period also, it is difficult to give these immunomodulators to the patient. So that's why in lactating mother it is not given, but otherwise we give a course of immunomodulator. So we think of it as more of a autoimmune kind of a disease. So there is no single line of like clear cut management for these kind of situation. So conservative medical management is currently endorsed as first line treatment. So previously when this disease was diagnosed, so multiple medical line of management was given, and afterwards surgical treatment was also given previously. So what they used to do, they first of all they used to do IND, that is incision and drainage of the abscess. But in most cases, as it is inflammatory, the disease used to flare up with these small procedure, and there is very minimal healing which used to happen. So nowadays we doesn't go into those radical procedures, IND, and sometimes the disease was so aggressive and it has involved almost all the breast that in some cases it is written in the literature that mastectomies was also done for some patients. So if we talk about the etiopathogenesis, why this disease happens, so this is the normal structure of the breast, as you can see. So these are the lobules, and these are the ducts which are draining into this lactiferous sinus, and which is having opening on the nipple. So what happens? It is seen that in these kind of situation of IgM, it mostly happens. The main precipitating factor which is there is the breast milk. There is lact albumin which is there in the breast milk, which tends to stimulate. Sorry. So yeah. So there is something which is called as lact albumin, which is there in the breast milk. So during the time of the lactation also, so this usually happens 6 months to 5 years after the pregnancy or after the breastfeeding session of the patient. So what usually happens, that lact albumin which is there, it usually tends to irritate, or basically the ductal epithelial lining, it usually irritate that epithelial lining, which will cause damage, or if you can see, there is breakage of the continuity of the ductal epithelium which is there. So what happens when it is there, it will cause efflux of the protein which is there, and it comes in the lumen of the duct, and sometimes it used to travel to the lobule, and it is used to cause lobulitis kind of a thing. And sometimes these can lead to formation of micro abscesses, and sometimes micro abscesses can combine and lead to a formation of a big palpable kind of a abscess. So nowadays what we are doing, so what happened when there is irritation, there will be macrophages and neutrophils which used to come, and there is a kind of an inflammatory response which is seen. So what we used to do nowadays, we are not doing the any IND, we are using the USG guided technique for aspiration of those abscesses. Because if we do the IND, so there is a so it is mostly unilateral, and mean age is so seen in men and the individual. mastitis, and history of lactation and pregnancy. So more than half of the patient reported has a pregnancy within 5 years of preceding the diagnosis. As I said, the mean duration is 3 to 36 months, and the onset occurs 6 months to 5 years after the breastfeeding cessation. There is
Is
no
your Ritika, is your slide moving? Yeah, now it has moved. Okay.
okay. So there is no association reported between the granulomatous mastitis and any future breast cancer. So the exact etiology is unknown, but they have still divided into two subgroups. One is specific and one is non-specific. Specific, I will be coming. Non-specific is, like I told, idiopathic granulomastitis. So there is no identifiable cause, and sometimes there is another etiology called chronic neutrophilic granulomatous mastitis. It is all the histopathological diagnosis. The other precipitating reasons for this is alpha 1 antitrypsin deficiency, oral contraceptive use, lactation, hypoprolactinemia, smoking, trauma, diabetes, and even autoimmune diseases. However, pregnancy, lactation, and hypoprolactinemia, they are the only condition which are clearly associated with IgM. So yeah, this is what I have explained. So this is the ductectasia, and then there will be a perforation or the continuity is disturbed, and there will be contents which are coming into the lumen and going up to the lobule, causing globulitis kind of a thing. So the clinical presentation, mostly the most common clinical presentation is a palpable lump. In 50% there can be erythema and swelling, 37% there can be an abscess, and mostly it is a subareolar region. So usually when the patient will come, they have suppose a fistula or something, some color changes or erythema which is there, it will be close to the nipple or the subareolar, but the subareolar area will be least affected. So sometimes there will be some fistula here and you will give all the treatment and then it will be healed. Then there will be somewhat a new lesion nearby. So it is close to the periareolar region, but never the subareolar region itself is never involved. So when an abscess is present, a sinus or fistula formation may develop because whenever there is something, it needs some space to come out, any abscess in the body. So it makes a track or a fistula and it comes out because of that. And it may also develop because of disease progression. So sometimes if you are doing lot of INDs also, it will lead to non-healing ulcer and prolonged fistula formation. So it is not advisable nowadays. So the disease tend to develop over weeks to months and may mimic malignancy. And symptoms can persist as short as 6 months to 2 years, but overall the disease tends to be self-limiting. There are multiple studies which have shown in which they have not given anything to the patient. I'm talking of a non-lactating female, and the disease itself is self-limiting. So after 2 or 3 years, the disease has resolved on its own also. If we talk about imaging like ultrasound or mammogram, but there are no clear-cut pathognomic feature which we will see on the imaging. Sometimes there can be a localized collection, sometimes there can be a mastitis kind of a picture, sometimes there can be fistula or the sinus tract which is seen. Whenever we see those collection of fluid, so that time only we tend to do remove them with the ultrasound guided procedures. Aspirations are done. These are only the therapeutic procedures. So this is a long list of other causes, the differential diagnosis of IgM. But as I said, this is the diagnosis of exclusion. So we have done all the workup and then we came out to the conclusion that yes, it is granulomatous, idiopathic granulomatous mastitis. So all the patients who are suspected with IgM, they require breast imaging and then core needle biopsy to confirm the diagnosis. TB should be ruled out, and whenever there are other symptoms like joint pain or something like that, if you suspect, then I usually tend to refer to a rheumatologist because then they can start them on methotrexate or azathioprine also to rule out any underlying autoimmune disorder. So most common bacteria which is seen in these cases of granulomatous mastitis is Corynebacterium streptococci. So for that, antibiotics have given, but they have not shown any good response. Inflammation. So by giving multiple line of antibiotics, still the disease is there. It means that it is an inflammation, not something infection. So with multiple line of antibiotic also, the disease will not respond much. in these kind of mastitis. So coming on to the role of surgery in these cases. So as I said, the role is very controversial. Sometimes when suppose we have given all these line of treatment and still there is a small lump which is still there after 2 years or 2.5 years, and patient is very much apprehensive about that lump, that time when everything is settled, then we can give an attempt of a wide local excision of the lump. When we see everything is fine, means there is no erythema, no fistula, everything is settled, only then we can give this option to the patient. But otherwise, the role is very controversial. As I said, repeated intervention will lead to more inflammation and it will increase the disease severity. So less invasive. So here the less is more. So what we used to give, as I told, ultrasound guided aspiration and intralesional injection of the steroid. By giving intralesional, obviously there is very good outcome. There is no side effect of that of oral, but there is not able to breastfeed the affected breast with the topical steroids. So how to do the intralesional steroid injection? This is the video. Try if it's loading. I'll try to show you. So what was done is whenever the patient come, we clean the area of the breast, and then if there is any palpable fluid collection, if we can see, we just palpate it with the syringe. Sometimes there can be multiple abscesses, multiple lobules are involved, so we used to send them for ultrasound guided. But otherwise, if there is a clear cut thing, you can also aspirate. So what we do, there is a 1 ml vial of triamcinolone acetate, which contains 40 milligram of the steroid dose. And we used to mix that with lidocaine or the 2% plain lignocaine injection, because whenever you are injecting that thing in the patient, so the cavity, basically the what I can say, the walls of the lesion which is there, they are very hard. So when we inject, that patient is having a lot of pain during that time. So best thing is to give a 2% lox, or what I do, I used to spray lox spray also before giving before injecting any steroid dose. And then I mix the rest of the thing 7 mm with the normal saline, or you can use a sterile water also to make it 10 ml dose. So then we used to palpate the cavity, and we used to give those injection intralesionally to all the walls, superiorly, inferiorly, medially, and laterally. And once in 3 weeks we can give, and we can try for 3 to 4 cycle of these doses. And in most of the cases, it will resolve. So the treatment option first, as I said, is observation, which we can't prefer to do in obviously in the lactating mothers. Then our antibiotic along with the steroid and immunosuppressant. So immunosuppressant do have a role. Azathioprine is something that can be given during the lactation also. So I usually tend to send them to a rheumat so that they can see what dose to start with, because methotrexate cannot be given during the lactation. And then of course surgery, but that is the last resort that we go upon. So, avoiding use of methotrexate, which is generally incompatible with the lactation, and azathioprine is compatible. So, what we used to tell the female in which we are giving topical steroid is to stop the breastfeeding and pumping from the affected breast. But we also usually, I used to send them to a lactation consultant where they can augment the unaffected breast and try to get more milk production from the other breast, utilizing the intralesional steroid on the affected side. So for pain management, we usually give them NSAID or acetaminophen for the conservative management, or sometimes a cold pack also. Repeated antibiotic treatments are not effective, and it can result in unintended and unavoidable circumstances, and it will not lead to any improvement in the disease. And during that time, first of all, we use, whenever this diagnosis come up, so we have 15-20 minutes of conversation with the patient, in which I used to tell them, see, this is a disease. It is not like a normal cold or cough that it will go within a week or so. It might take some months to years also. So we have to be very patient in it, because usually patient tend to go for doctor shopping in these cases, because they will see, okay, इनसे लिया था कुछ नहीं हुआ, so maybe another doctor can give you something else. So we have to make them understand that it is a chronic inflammatory process and it will take its own time to heal. So this psychological support is very important for the patient, because she's in lot of pain and discomfort also. And involvement of lactation consultant is very important in unilateral weaning to assume adequate milk supply and to offer breastfeeding support. So the traditional treatment has included the systemic immunosuppression and surgery, like I said, but newer literature demonstrate a significant symptomatic relief. So it is always an individualized care which should be provided with consideration of the side effect of the steroids. Thank you so much. Actually, I've recorded today only the one of my patient came in which I've injected the steroid. So this video is not
Thank you so much, Ritika. That is really an eye-opener presentation. And indeed, it is very unusual, and one can really get
yes.
confused with what is the diagnosis. So, are you going to show that video, dear?
Yes, ma'am. I'm trying actually so that.
What you do is,
Okay, so what?
Ritika, open that window in your background and then
Yeah,
because
just
stop
Okay.
close
sharing this
this
screen.
and
Stop sharing
yeah,
this screen.
Oh,
then only the video will come on. I'm not sure if it will open directly like this, but if you have it as a
No, once she has this window
standalone
up over here,
video,
she can click the
mm,
start button. So she has to keep it in the background,
yeah.
one of the screens.
okay. Uh, can I
Or even,
share that in the
yeah,
group?
directly you share. Don't share through this. You can directly also, if you have on your laptop, you can share it directly there. But
Yes,
then you
ma'am.
have to stop this screen.
She'll have to stop this screen because well, it picks up the screens that is like Zoom, exactly like Zoom. Yeah,
Okay.
so just stop sharing. So that is good. Now open that, minimize this window of Zoom. Minimize
Okay.
this Zoom window from the top, from the right from the top.
Okay, sir.
Right upper corner. You minimize this
Okay.
window.
So I'll open my WhatsApp otherwise.
No. What you do is that you minimize this window right from top.
Okay.
Right upper corner. There are three signs: close, minimize, and we make it small. So you can just
Yes.
minimize from there, and then open your video screen, which is there, and then share that screen again. That window.
Okay. Actually, I've recorded it on my phone, but
So
I'll
then
just try.
you'll have to upload it on your Gmail or, I mean, email, download on your computer, and then
Or
you
I'll
can.
I'll pin you up over here. We'll remove, so you can just reverse your WhatsApp for phone and show your video over here. Will that be okay?
Okay.
एक minute. Just a minute. I'll
Yes.
maximize you over here. So you are on maximal position. Is everybody able to see her maximally on the screen?
No.
No, we don't see.
No? No, everybody of us have got different screens. So I'm also getting confused that what I'm seeing over here, is it being seen by everybody
Yeah,
else, or all of us are seeing some different things?
but we
No,
don't
we
know
are
what
seeing
you are saying.
everyone.
You can go right on the
Ritik,
top. I'll tell you one thing for the audience. Go on the right top. There is something called view. In view, you click the option where the it's a speaker option. Click the speaker option. Go up. Right at the top, there is something called view. So to click speaker option over there. Did all of you get now? Did you get
Yes.
that view at the top?
Ritika, WhatsApp me. I'll immediately download and then share the screen.
Give me 1 second. Yes, ma'am.
But tell me if you're doing it or.
Yes, ma'am. I've sent you, ma'am. Abhi
Okay,
it's
wait.
going.
I haven't received it as yet.
Yes, it's going.
Sir, meantime, can we
I'm sure you must have seen some cases which are very close to this particular cases. So I was wondering whether you people have seen any such case of this kind. Please, everybody put on the video. Let's go into gallery
I
view.
think Lukmita has seen.
She's there right now.
Yes,
Yes,
yes, sir.
Lukmita is there. And I will comment after Lukmita presents it. Yeah,
Yeah,
Lukmita.
yeah. First of all, Dr. Ritika, lovely presentation. And to everyone, I want to say, Dr. Ritika has been a very great help to me, and all my mothers that have referred to her. So yes, and she's available on the phone, and anytime that you want to talk to her, she guides you very well. So lovely presentation, Dr. Ritika. I had seen
Thank
this
you.
mother like almost 1.5 year back and with the same symptoms, but then she had delivered, and after a month, she started getting this symptoms like mastitis. First, she had this soreness in the nipples, and after that, immediately after 1 or 2 days, this mastitis flared up, and within a day or two, she had this redness and fever and everything. So she went for an ultrasound, and after doing the ultrasound, uh, her radiologist diagnosed it as breast abscess with mastitis and everything. And when she went for the surgery to, IND, the gynec could not basically, she found only somewhere around 9 cc of pus inside. But yes, the tissue looked quite different compared to, like, after the surgery. That's what the gynec said. And then, rather than kind of getting cured and healing, she developed this sinus again, and there was pus discharge from the sinus, from the other side of the breast.
Lukmita, it was needle aspiration or was it IND?
IND.
Okay.
Yeah. So that also was not getting cured. So then she went to one of the breast, I think, radiologist somewhere in some other place. And that's where that radiologist picked up that this doesn't look to be like a normal mastitis. So you should show it to the surgeon, like the breast surgeon. And that's how, like, the doctor, like with all the ways, they found out that this is not like a normal mastitis. And after the surgery also, the tissue was sent for histopathology, and that's how they came to know this was diagnosed as granulomatous mastitis. And same, like, the mother was put on immunosuppressants and everything and all. Yeah, so almost the same.
Anybody
Yeah.
else has seen these kind of cases?
Hello, sir. I want to talk.
Who is that? They have three or four
Anisha.
screens, so it's very difficult to.
Before 1 minute, before any questions, should I show you all the video? Can the
Yeah, yeah.
host make me a co-host, please?
You're already a host,
Um,
madam.
no, I'm not.
Ek minute, let me check the screen.
Okay, now I think. All right. Can you all see?
Yes, yes, we are seeing.
Okay, I'm just starting it for Ritika.
Yeah. Yes, thank you, ma'am. So this patient, she has, I think, 3 years post her 1.5 year post her breastfeeding. She came to me and she had this kind of a picture. So this is the lock spray that I did before. This is the triamcinolone vial.
Log spray means lignocaine spray, right? So because many people will not understand what is log spray.
Lignocaine spray.
Okay. Local anesthetic spray.
Lignocaine spray, 10% spray. Yes. And then what I do, I take 1 ml of the triamcinolone acetate, 7 ml of this normal saline, and again 2% of lignocaine because there is lot of pain while injecting also. Some people they use 2 vials also, and it also come in 10 mg. Like 40, like I'm using 40 mg. It also comes in 10 mg, but I usually use 1 vial 40 mg.
1 ml is how much you said?
So
Concentrated?
sometimes
1 ml is how much?
40 milligrams, 1
1
ml.
ml is 40.
So
Okay.
40 milligram. It also come in 10 milligram, 1 ml also. This is the LOX 2%, lignocaine 2%. So after all aseptic precaution, firstly I just palpate the induration or any lump which is there. So there are two areas which I can see the induration. For this patient, I am giving her for the third time. Means she came to me in third month, and there is hardly any lump which is seen now as compared to the previous when she came to me. So this is how we palpate the cavity, and then we just poke, and then we indurate. Then we just deliver that drug there, anterior wall and posterior wall. This was the main area. This upper outer quadrant was the main area, and you can see also there are. This was the discharging fistula which was seen previously. This was the discharging fistula, and here also there are multiple sinuses which has healed now. Once you go in, you can actually feel the wall. Like there is a giveaway which is there, and you can actually palpate the wall of this mastitis.
You're injecting inside the mastitis mass or you're injecting at the periphery of the mass?
At the mass, sir. So the mass is palpable. So anterior, posterior, medial, lateral wall. So anterior and posterior are able to palpate. In like you can make it anterior or posteriorly
So
in
you're
that
not injecting the
mastitis
center,
mass
you're
only.
not injecting into the
So
center of the mask, right?
no,
Okay.
no, on the walls.
Okay.
Thank you. I stopped shared because it was repeating itself. So I know that there are many questions, so we'll take one by one and then. So Manisha Khellani has written that, Hi ma'am, I have a question. Recently, one of my patient visited me. She is a known case of SLE, already on steroids, lactating, fully breastfeeding mom. Her breast swelling increases in one day, develops complete redness around the breast. In such cases, how steroid is helpful and need to decrease the steroid.
Yeah. So I usually give steroid only this in this particular kind of mastitis, because if there is something a normal breast abscess, if we give steroid, it is going to flare up the things. So and we can't give, like, it is not an over the counter medication which needs to be given. Only if I diagnose it as granulomatous mastitis, I give them steroid. But
But she is a
otherwise,
case of
Yes, ma'am.
SLE who
SLE,
as she's a
okay,
case of
SLE is there.
SLE, so she would
SLE.
require the steroids. But instead of steroids, can she use other immunosuppressants
You know what? So,
or
what we
modulators?
use, yes, ma'am. So, what we used to give in Tata is a Guduchi tablet. It's a kind of a Ayurvedic thing. So, patient can keep on taking that
Sorry, can
tablet
you
for
repeat
six
the
months or
name?
so, and then they,
Can you repeat the
sir,
name, please?
ma'am, Guduchi tablet.
Please type in the
It
later in
Ma'am,
it
the
can
comes
I
as
chat.
speak,
good.
please?
Yeah,
Can
I
I
like.
speak?
कौन बोलता है
One
कुछ
minute, let her
Yeah.
complete,
Manisha
please.
Kalani.
One
Manisha
second,
Kalani.
Manisha. Let her complete and then I'll tell you. Yeah, yeah, Ritika. So you give that tablet,
Good.
goodwill,
Yes.
goodwill.
It is a kind of
Guduchi.
immunomod.
Yeah, okay. So now Manisha Khailane.
Yes, thank you so much, ma'am, for giving me this opportunity. The case told by the madam is the question sent by me. The patient already on steroids, so I told her to take a opinion of her medicine doctor to decrease the dose of steroid. But her doctor says that steroid is not a issue with such type of mastitis. They directly said to the patient, कि Steroid will not flare up your mastitis. It is a different entity. So recently she has come just 2 to 3 days before to me. So I send her back to her gynecologist, and her husband is surgeon also. So I told her to take a opinion of surgery also. So in that case, what is your opinion? Is there is a need to decrease the steroid because she is on 5 mg prednisolone or something. Daily she is taking that medication.
And this
No,
spelling,
you're muted.
like this
Ritika,
is
you
the
are
first
muted.
time it has happened, or it is a recurring?
Hey,
Okay.
this is the first time. She's
No, I'm
a
not
fully
muted.
lactating mother, fully baby is on complete breastfeeding, and within one day
Okay.
she noticed the swelling on the breast, and after that it's increasing. And she also prescribed amoxicillin, but it is not working with the amoxicillin also antibiotic. So we
So,
send our milk to the
yes,
culture also, that her breast milk coming from thick milk is coming from the breast is sent for culture and sensitivity. The report will come within 2 to 3 days, but I think steroid play a major role in aggravating the situation because she already immunocompromised
yes,
patient. So, but her
yes.
medicine doctor says that the steroid will not play that much role in that cases. That's why I wanted to take opinion of yours also.
Yes, ma'am. So what we can like 5 mg steroid, obviously they will taper and they have to make a balance because she's having SLE. So what you can do,
Right,
you
right.
can use a wide bore needle and you can just send the pus for culture and see what antibiotic works. So here we should give her a
Do
course of
that. Okay.
antibiotic which she's susceptible to.
Right.
Exactly.
And
I think I would do that, that give her a good trial. Amoxicillin is not that good. You can even go up to Vanco or to clindamycin, which is given, you get oral higher cephalosporins, which can be tried. So try those before, so straight off going for more measures. And in
right.
such people who have autoimmune disorders, I think a little tweaking on their other drugs also can be done. That's what I think, but I leave it to Ritika to comment on it.
Yeah.
Yeah,
So
madam.
basically,
Mm.
they also use immunomodulators. So this Guduchi tablet, if given for 6 months or so, it has a very good result, even if we are not giving steroid. Because sometimes I also seen sometimes there is so much of infection that with steroid it will flare up.
Mhm.
So if we give this Guduchi tablet in non-lactating mothers, especially, so they have a very good result with Guduchi alone without giving steroid also. So
So does it have
there is
side
this
effects in
no,
lactating
ma'am.
mothers, this Guduchi?
So lactating mother, it is ideally it should not be given in the lactating mother. But like I said, this patient come to me after 1.5 year of post lactation, and that we can give. But during the time of lactation, it can't be given. So that time we have to do repeated aspirations. That is the only thing. But no need to do that IND, but repeated aspiration, and we have to balance between the steroid and because she's having SLE, so we can't stop that. But 4 mg is not that a big dose. We
Yes,
usually give
5 mg is really nothing in with such a body weight of a
nothing.
lactating
Yeah.
mother, whatever be the weight. I also want to know, if you do repeated aspirations, what is the chance of developing sinuses? And
So,
when
ma'am,
you're
if we
injecting, triamcinolone.
So, ma'am, actually, if there is some collection in the breast, it will make its root to come out. So, if we are doing multiple aspirations, like I usually call my patient after 2 or 3 weeks, and while doing like it is always a USG guided because there are some micro abscesses here and there which you can't target it blindly. So if you're doing aspiration, there is no abscess, so there is very less chance of sinuses being developed. But if so, I usually prefer to do micro abscesses. It can be done twice weekly or thrice also.
Okay.
And if we are draining it, so there is no chance of any sinus or any fistula, which usually develop if there is a collection which is retained for a longer period of time.
Okay.
Thank you.
I see the hand of Dr. Manglavani.
Nice case, Ritika. Well managed. I saw the video, and the syringe and the needle, and your needle was curved. Is that with the purpose you made the
Yeah,
in the needle, or
yeah,
was
yeah.
it just because of the resistance it got curved?
Yeah. Yeah. So yes, ma'am, you have actually visualized it, like you saw it
Yeah,
very
me
nicely.
too. I
Like
saw it.
you have
Because
projected.
I do many
Yeah.
aspirations breast abscesses,
Okay.
because what I feel,
Yeah.
if needle
So,
is straight, it comes
hmm.
easily. If it is bent, of course, there is a problem, So that is why I have asked you this question.
So, so, ma'am, what usually happens is because we are not poking or going straight in the cavity, we have to go to the capsule. So, from the surface, we usually bend it. Matlab, it is bent so that it goes easily to the cavity because we are not poking it. So, it will be with means no, not perpendicular, but at least parallel to the surface so that it reach the wall. And I uses usually 24 or 28 gauge, like a very thin needle, so that it goes inside the cavity, deliver the drug, and come out. So it is usually
Okay,
I usually bend it, yeah,
right, right.
for
And
proper drug delivery.
so
Yeah.
when you said when you inject steroid, you don't allow the breastfeeding from that side. Is that what?
Yes. 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 Because that
Why you
steroid.
don't allow breastfeeding from that side, or
Sorry,
it just
ma'am, I didn't. Yeah, so from that side, because the steroid, it will mix, like it will go with the breast milk also, and it will cause a lot of side effect to the baby. So I usually ask the patient to go and meet a lactation consultant so that from the affected side, there should be weaning off, which is done, and more and more from the non-affected breast. I usually try to focus on that because there is
Mhm.
still
so
like
that is what.
steroid has a lot of side effects. Yeah.
So that is what your another statement confused me. You said you advise pumping on the affected side to augment the milk supply on the unaffected side. So
Okay.
to me, um, I'm not aware of this, because when the woman breastfeeds on one side and there is difficult latching on the other side, actually the other side, the breast becomes even the small and there is no milk. One breast is stimulated, yeah, breastfeeding, but other side there is no milk. So that statement, if you pump on one side to keep the milk on the other side, I don't know what the others feel about this.
Yeah.
No, I don't think so.
So,
She said that, madam. What
Yeah,
she
she
said is
said that. There is a
no
statement.
breastfeeding from the affected side, and
And from the other side.
remove extra milk or engorgement to avoid engorgement.
No, 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 sir. She said that.
I mentioned it at one point, sir. Actually, in this patient, there is a lot of engorgement which was happening, and I told her not to feed. So she has used the breast pump also for 2 or 3 times. I think she has used it, but afterwards I told her not to do, and I usually send her to a lactation consultant to
So
means take care of that.
and
Yeah,
that's
you're
why I
right, ma'am.
asked you.
Yeah. Because there is a lot of engorgement because
Yeah.
suddenly I've started
No,
her
no,
on
you didn't
steroids.
mention that. That's why actually I wrote from your slide what it was written, and I thought whether I'm not aware of this.
No, no. So you cannot do it that way.
So the
Yes.
message, Ritika, you want to give is that on the side which is affected, mother doesn't breastfeed. But if she has
Yes.
engorgement, she can use a pump or hand to remove that excessive milk,
Yeah.
and she should
Yeah.
pump more from the other side, which will be the where the milk
Yeah.
supply has to be augmented, right?
Yes. Yes. Yes, sir.
Okay. Dr. Raghunath, he is also waiting for a shot. Dr. Raghunath, where are you?
Hello, hello. I'm audible.
Yes. Yes, sir.
Dr. Ritika, it is a fantastic talk. I just want to ask you a question. Has any role of hyperbaric oxygen role in such chronic mastitis?
Uh, Not really, sir. Like I have not. I'll also read about it, but I have not seen this because these are not the wounds or something. Means
Hmm.
if there is any open wound, or sometimes I've seen a patient with tubercular mastitis with multiple sinuses. There might we can use, but usually this hyperbaric oxygen works well on a wound which is a non-healing to make it into a healing wound. But in these
So,
situation, there is no wound clear cut which is there. So there is no role of hyperbaric oxygen. But I'll
but,
again see the literature if there
uh,
is anything which was done.
but a lot of influence. Giving 100% oxygen under pressure will supply a lot of tissues into the oxygen into the tissues, and it reduces the inflammation. No? So I thought that could help in
Yes.
such cases.
So I've never read about it or I've never done it, but I'll surely see and get back to you, sir. I'll see if
Okay.
this
Thank you.
we
Very
have
kind of
used
you.
Dr.
because we used
Keshav,
to
Thank you.
use that
Thank
for
you.
chronic ulcers. We usually use that for chronic ulcers or non-healing kind of ulcers. But yeah, maybe there is some role. I'll get back to you.
Dr.
Thank you. Thank
Keshavlu.
you.
Yeah, yeah. Good evening, everyone. Say at the outset, excellent talk, Dr. Ritika. Uh, I want to share my experience. So, though it is said that ultrasound guided aspiration is the right choice for managing breast abscess, so at a place like me, Hindupur, where it is a very peripheral place, we don't have that facility. So I don't know how many cases of breast abscess I've managed. I speak to surgeon and he is not well versed with aspiration. He used to original first one or two cases given a circular incision parallel to the areola. Then I told no circular incision, just give a linear incision. And then usually the surgeons what they do, no, they put a gauze and send it. I very next day I remove the gas, and then I will gently express around the wound and also on the areola, and I spray normal saline, physiological saline directly into the wound, and then I'll just close the wound with a sterile gauze and. Within a matter of a week that heals and I never asked a surgeon to do aspiration. I don't know whether I'm wrong or not, but somewhere I read again this multiple aspiration is gone. Now they are giving incision and draining the abscess. I don't know whether I'm wrong or right. Probably Shushma Malik madam and Prasad Gangal or Mangalwani may have can correct me.
So what did you say? What was done initially? IND was done or aspiration was done?
Yeah. IND.
IND.
Linear incision, not circular.
So when the IND is done and it is actively for the drain, they do pack it with gauze,
Yeah,
and it helps to prevent what my knowledge says, but I could be wrong. Ritika can correct us. It
madam.
helps to prevent fistula formation. Anyhow, I think we are a little bit diverting from the topic, sir. Maybe we can talk it out again. But Ritika, if you can quickly answer, sir, that would be good.
Yes. So yes, if it is a normal abscess, not a IgM, so we usually do this only. But yes, if it is not possible, obviously we have to drain the abscess somehow. So we used to pack the cavity so that whatever is the secretions are coming, they're absorbed, and there is an opening which is there for whatever secretions are left. Also, they should also come out. And if we are seeing healing and granulation, so we usually don't put the gauze and allow the granulation to come.
Here, I would like to add that in a normal breast abscess, only needle aspirations should be done.
Yes.
IND should be only done if the abscess is too large, if there are multiple abscesses which are not recurring abscesses which are not healing. Otherwise, there's no indication for doing IND, per se.
Yes.
So if
Yes.
And Sudha
somebody has
madam,
done the IND, then they are packing the thing with the gauze to prevent any further secretions, which is again not a very right thing. And of course, you should put the pigtail drain. That is what is given even in the latest management for the mastitis and breast abscess. Please refer to the ABM, protocol number. Is it 34 or 37? It's 34, I think. I think we'll leave it there. Ritika, I would want you to answer some more questions. Dr. This one, Manisha Gogri has asked you, I think I'd seen, after unilateral weaning, what advice do you give your patient for future pregnancy and lactation?
Um, so usually,
Yeah,
ma'am, this
Manisha is there. So, Manisha, you can directly also,
yeah.
ask. Okay.
So actually, it is a very tricky part because sometimes we see it has almost resolved, and another month we have seen it is all red and inflamed. So we can't predict this disease. It is beyond our imagination, like how the patient will respond. So there is nothing that we can't tell them not to do and go ahead with pregnancy. It's nothing, like nothing advice from my side. I don't give any advice, but I just
Okay.
tell them if you are planning, there might be chances of aggravating or precipitating the disease back. So day before yesterday, only one lady came to me. She already have two children, and then she came to know that her UPT was positive, and she is again having an episode of IgN. So in that case, I told her to abort. Means that was not any like precious pregnancy or something. So in that cases, because during pregnancy also it can flare up. So in that case, she has aborted, and we have started her on steroids. She was with me for last 3 years also. So
Okay.
sometimes we usually tend to tell
So
them
it's good you
beforehand if
took
it is
a,
not
yeah, good
right.
that you took a shared decision, with her, obviously, that she should abort,
Yeah.
and very important as a little caution, always take it in writing. They can always backfire on you. I
Ritik, I have
also
a question
wanted
for
to
you.
know
Uh,
that you had written in your options that surgery is the last resort. So, what surgery is your last resort?
So, ma'am, sometimes everything resolves, means there is no sinus, no inflammation, everything resolved, but some still there is a palpable lump which is there. And sometimes that is very, if patient is very much apprehensive, they used to tell, ma'am, there is something, kuch ho to nahi jayega. They're very much apprehensive. So in that, when everything resolves, only then we give them an option of a wide excision, in which we are removing only that lump when everything resolves. So that is, and we send it for histopathological examination. It is only the lump which is palpable which I have removed,
Okay.
and then also I usually send them for TB. Everything I used to send them during
Okay.
the like post
So,
op
there
also.
are one or two
But
questions, and then,
otherwise,
I have a
yeah.
question for Ritika.
yeah.
What dose of
Yes, sir.
hello?
Please mute
Guduchi, sir.
everybody.
Yes, yes, sir.
Pushpa, please mute your mic.
I have
Ritika, what
muted her.
dose of oral steroids is all right for a breastfeeding woman? So, have you done some research on that?
So, what it is written always weight like whatever the milligram like by weight we used to give, but I used to give half the dose. Suppose the patient is 50 kg, so I usually tend to start with 20 or 24 like that, and then we used to taper. First, we see the response in the first week or 10 days or so. Once the response comes, then I used to taper the dose.
Okay. Second question is, as I can understand from your presentation, the only diagnostic thing that would differentiate infectious mastitis from granular mastitis is the biopsy, which will show granulomas, right?
Yes.
Now, this biopsy, is it a needle aspiration or is it actual tissue which is removed in IND?
So it is the proper true cut gun biopsy, sir.
The gun biopsy. Yeah.
It's a
Gun
gun
biopsy.
biopsy.
It is
It's
Yes.
a
not
gun.
not a part of the IND, right?
No,
No, so
sir.
for true cut also you make a little very micro, like extremely small little incision, and a true cut needle is done, and it's a
Yes.
good amount that is
Okay.
removed. So
Yes.
it
So,
is a proper
So
biopsy.
I think when one
Biopsy.
is not sure, the first thing that should be done is a true cut biopsy, and seeing the granulomas is what would clinch the diagnosis. That is number one thing.
Yeah.
Uh, Second thing is I was
I
just seeing the literature today for granulomatous mastitis, and I found a reference to a lot of Chinese medications which have been tried out by Mr. somebody called Wang for treating this kind of mastitis. So is there any kind of traditional medicine like Chinese medicine which has been thought to have a role in this, like just like you said about Guruji? And then there is also note about the success of your therapy, especially triamcinolone, being how early you give it in the disease. So can you just
Okay.
comment on these particular two things?
So Chinese, I don't know actually. This Guduchi is also an Ayurvedic thing actually. This is an immunomodulator and an anti-inflammatory
Yeah.
property. So we
So
No, I'm
used
not
to give.
talking about
basically,
Google search. I'm talking about Google, review articles on proper
Okay.
Google Scholar. So
Okay.
there are many articles on the Chinese therapy. So maybe you can have a look at those particular things. They're not anecdotal articles on Google
Okay. Okay.
or at
Okay.
YouTube. Hmm?
I
Okay.
also wanted to know how often is mastectomy done because I've come across a case where mastectomy got done, which is very wrong, I felt.
Yeah. So very rarely, ma'am, because in the beginning, when they don't know about what the disease process is, so I have seen there are two cases which are reported in the literature, but I have not seen any such case. Means it should ideally not be like it should not be done for something benign as a mastitis. So we
Absolutely, absolutely. And this was done. So I think Lukmita can vouch for it. Lukmita, where are you? Lukmita, unmute, please.
Yeah, it was done, ma'am.
It was done. See how ignorance can cause, and it was a mastectomy, it was a total mastectomy. Radical कर दिया उन्होंने. ऐसे partial भी नहीं.
अभी तो हम
I felt
कैंसर
so
में भी हम
sad.
ब्रेस्ट कॉन्जर्वेशन कर रहे हैं. Yeah.
Absolutely. They didn't do anything. And that's why, from last 1.5 year, I've been telling Lukmita also to present this case because people are not knowing about it. And, they are like ignorance is bliss, and they did the
Yeah. And
mastectomy.
and the kind of I mean, the solution what Dr. Ritika has offered, that's really great, without any
Yeah.
uh, incision or without any mastectomy. I mean, it will preserve the nipple areolar complex also
Uh,
and continue with
yeah.
lactation and
Yeah.
future lactation
Same.
process also. So really nice.
Thank you, Ritika.
Yeah. And this Guduchi tablet dose.
I
So,
read about it also. What is the dose?
so ma'am, usually we give 500 mg BD for 3 to 6 months. Tend to give them. I usually call them after 2 months or so just to see the response. But I've never seen any side effect. And even when everything is like I've weaned off from the steroid also, so I used to give only Guduchi. So for 6 months, I usually prescribe. So there is a recent publication which has come up from Tata Hospital also, in which they are not promoting steroids and they have given only Guduchi to the patient, and there is a quite a good response with only Guduchi. Obviously, non-lactating mothers, I'm telling non-lactating patients.
Okay.
So
Thank you. Anybody for any last question? We have already overshot our time. So is Sangeeta there? Sangeeta?
Yes, madam.
Yeah.
Yeah. So it was really an awesome eye-opening session because most of the time when we see mastitis and 24 for 72 hours wait and 48 hours and start antibiotics, but all the mastitis are not infective and inflammatory. We have to keep our eyes and mind open for that. So it is really an eye opener, and we have to look at with a different perspective. Always keep your eyes, mind open, and treat the patient. And whenever needed, take a help of seniors and the proper consultant like surgeons, breast surgeon. So that will be my take home message. And again, Guruchi, that was again a good thing.
yeah,
To know that we actually ignore our home own Ayurvedic practice. So it was really a nice session. So I congratulate you, Dr. Ritika, and I am again very grateful to you for granting for this session. I am also grateful for all the BPNI Maharashtra and UNICEF for this Zoom support and
And
all
And
the
Nutrition
delegates.
Bureau.
Nutrition Bureau also.
Nutrition Bureau, yeah. So, and thank you to all the delegates, participants who have participated in this. I hope it has added value to your knowledge and it will be very helpful in your future patients whenever you will come across to any mastitis patient. And if it is not responding and something is different, then you will uh, investigate it little more and will take an advice or second opinion of breast surgeon or someone who is expert in this. So thank you so much once again. And I hope we will meet again for the next session after 15 days
14
uh,
days.
with this huge audience. Thank you so much.
And thanks Abhijit
Thank you.
Kusre sir also, who has been managing this particular eco session for us, the recording, and Shalini, who is there with her friend to for managing the background with Abhijit. Thank you so much. We meet after 14 days again.
Thank you, everyone.
Thank
Thank
you,
you,
ma'am.
ma'am. Thank you, sir.
Thank you, sir. Thank you, ma'am.
Thank
Thank
you.
you.
We have not taken screenshot this time. I think people